Assalamu alaikum dear doctors. In this video I am discussing a blue case, that is tetralogy of Fallot. In examination how the question come, that is like refuse the child who is 8 months old with cyanosis, faltering growth and recurrent chest infections. Murmur was unclear and with unclear data concerning radiation to other areas. Differential diagnosis, investigation, team and advice, these are the question on Viva they ask. So let's start, that is pulmonary stenosis with TOF. First, when we enter the room, we can find any special features like maybe Down syndrome, the child is small for age, blue or pink with or without clubbing, plethoric face and conjunctival injection. In exam, cyanosis was present in this patient. Pulse actually non-specific, neck with or without suprasternal thrill due to pulmonary stenosis. Inspection, we find median sternotomy scar or lateral thoracotomy scar, right or left if failed RT. So there is a scar mark presence. In apex, what we find? Pulmonary stenosis murmur, that is a ejection systolic murmur with maximum intensity on the second left intercostal space, increase with inspirations, plus minus radiated to the back between the scapula with thrill. Palpable S2, left parasternal heave is present. And investigation we do for TOF, that is echo is diagnostic, ECG that show right axis deviations, right ventricular hypertrophy and tall P wave. Chest X-ray show boot-shaped heart, prominent right ventricular and small pulmonary artery and lung oligemia. Full blood count, there is we find hematocrit 60% more than, to give him advice to try to decrease the blood viscosity to avoid the cyanotic spells, thrombovascular accident. ABG, we find the metabolic acidosis. Now what are the complications of tetralogy of Fallot? These are cerebrovascular accident, brain accident, thrombosis, cyanotic spell, failure to thrive, arrhythmia and infective endocarditis. Management. How can we manage the hypercyanotic spells or TOF? These are first positioning, squatting positioning for the old children and knee chest position for small baby, 100% oxygen, decrease the irritability, anorexia and decrease the stress. We give the hydration with IV fluids, then BV, vasodilatation of pulmonary infundibular. Sodium bicarbonate to correct the acidosis, we give morphine, we give the phenylephrine or noradrenaline to increase the systemic resistance. We give packed RBC. Intubation in emergency surgical intervention for BT shunt. Now what are the component of TOF? We know that 4 component of TOF, these are pulmonary stenosis, right ventricular hypertrophy, VSD and overriding aorta. Red flags of TOF are, that is any chest pain, dyspnea, arrhythmia, pulmonary embolism. So these are red flag, chest pain, dyspnea, arrhythmia and pulmonary embolism. In exam, they also ask what advice you give in this patient. For all cardiac cases, recommended for any cardiac case, we give the advice: number 1, good oral hygiene. Number 2, restriction of the exercise, not needed. Especially needed on except the case of severe aortic stenosis and hypertrophic obstructive cardiomyopathy. Other than not indicated. Number 3, avoid the piercing and tattooing. Number 4, good nutrition. Number 5, plus minus antibiotic prophylaxis against the infective endocarditis according to the guidelines. Number 6, if cyanotic, avoid high altitude, take iron supplementation prophylaxis against infective endocarditis. 7 is valve replacement and infective endocarditis, use of anticoagulant. Team. What are the team involvement we when manage TOF patient? Will tell dietitian, cardiologist, cardiosurgeon if indicated, dentist, liaison with the school, support to the family and other team according to the syndrome. So this is all about tetralogy of Fallot, which can be associated with pulmonary stenosis murmur, and baby presentation can be cyanosis in the exam. That is an exam question and the Viva question. Thank you.